You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 1st, 2019. This week, AF ablation, cardiac rehab, hypertrophic cardiomyopathy, and clinician wellness. First topic today, as if on cue, a mere few weeks after my column on paying attention to the asymmetric downside risks of AF ablation, the Journal of the American College of Cardiology publishes an observational study of mortality after AF ablation. The authors, mostly from the Weill Cornell Medical College in New York, used a readmissions database of adults from 2010 to 2015 who had an AF ablation. The total number of administrative records from the database was large. It was greater than 60,000 patients. And hospitals were stratified by volume tertiles, low volume, middle volume, and high volume. The primary endpoint of the study was all-cause mortality, which was defined as death during the initial hospitalization or a readmission within 30 days of the procedure. Early mortality occurred in 46 per 1,000 cases. To be clear, my friends, this is almost 1 in 200 patients dying early after an AF ablation. Shockingly, figures 2 and 3 in the paper show that the quarterly rates of early mortality and complications after AF ablation increased more than 5-fold from the beginning to the end of the study. Notable too was an average complication rate well above 6% in 2015. Now I use the adverb shockingly because the normal pattern for procedures is that complication rates should decrease over time, not increase. This is because of iterations of catheters and mapping programs should make it easy. Plus, the growing skills of human doctors should, emphasis on should, make the procedure safer over time. After adjustment for age and comorbidities, the authors found that procedural complications was a strong predictor of mortality. The odds ratio here was over 4. Congestive heart failure had an odds ratio of over 2. And the other predictor of mortality was low hospital volume on AF ablations. Here the odds ratio was over 2. Complications due to cardiac perforation, other cardiac complications and neurologic etiologies were also associated with early mortality. Now, before I move on to the comments, it is vital to set out that this study had limitations. Of course, this was an administrative database and these data sets are far from perfect. That said, though, I am struck not so much by the absolute rate of death, but the clear rise in death rates after AF ablation. Now, the always thoughtful and curious commenter, Professor Hugh Calkins from Johns Hopkins, has a very nice editorial. The title kind of gives it away. His title is, When It Comes to the Mortality Rates of Catheter Ablation of AF Ablation, Experience Matters. Now, he writes, at the end of the day, this is a very important study that should serve as a wake-up call to all electrophysiologists who perform AF ablation, all cardiologists who refer patients for this procedure, and all patients who are considering undergoing AF ablation. I completely agree, and as I wrote in my most recent column, which I'll link in the show notes, AF ablation is a serious procedure with serious potential complications. This data adds confidence to the notion that while AF ablation can help people, it is not a small procedure. Mortality is a very real complication from this procedure. The authors, led by Dr. Edward Chang, have added a lot to the clinical community, and they, along with Journal of the American College of Cardiology, should be proud of this sobering publication. The second topic today is that cardiac rehab has long been established for patients who have had coronary revascularization, myocardial infarction, and more recently for patients with heart failure with reduced ejection fraction. Incidentally, I would add that pulmonary rehab for patients with chronic lung disease has always impressed me as an extremely useful intervention. Recently, researchers from Vanderbilt, publishing in JAMA Cardiology, performed a cohort study of Medicare-age patients who had cardiac valve surgery in 2014. Their primary outcome was the association of cardiac rehab enrollment with one-year hospitalization rates and mortality. Their sample included more than 41,000 patients who underwent valve surgery in the United States. About 43% of these patients enrolled in cardiac rehab. Cardiac rehab enrollment was associated with fewer hospitalizations within 1 year, even after adjustments. Cardiac rehab was also associated with a 4.2% absolute decrease in 1 year mortality. Here the hazard ratio was as low as 0.39. And this was also after adjustments. Now, the authors also noted disparities in enrollment in cardiac rehab. Asian patients, Black patients, and Hispanic patients were much less likely to attend cardiac rehab than white patients. And finally, the authors note the benefits of cardiac rehab held up for patients with valve surgery alone compared to those who had valve surgery combined with bypass. Senior author Dr. Justin Brockman called cardiac rehab a no-brainer, and I agree with him. Now I know what you might be saying. A purist could say, Mandrola, this was not an RCT. You can't really say cardiac rehab caused the better outcomes, which is true, of course, but I still think that cardiac rehab programs have much more upside potential than downside. They are low risk, they're not too costly, and they help patients who have severe disease get better. What I love about cardiac rehab programs is the humanity of them. Yes, the supervised exercise is good physically. We occasionally pick up important dysrhythmias, for instance, and the education is also good mentally. But I see the biggest benefit of cardiac rehab as the immersion of a patient in a community of healing and other humans. This environment is good for the mind-body connection. Now, while a young person who has isolated valve repair and no other disease, they might get little benefit from cardiac rehab, they're going to get better quickly. The vast majority of people who have valve surgery are older and have more comorbid conditions. These patients, I think, stand to improve in the healing environment of cardiac rehab. So this was a good study. The third topic, and speaking of good studies, is on hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a feared disease in young people. The general teaching holds that when a young person dies suddenly, the most common cause is hypertrophic cardiomyopathy, and it's a frequent reason young people are disqualified for sports participation. Yet I see this condition frequently overdiagnosed in the community setting, even patients getting ICDs, likely inappropriately. That is why I was drawn to a Canadian study of all hypertrophic cardiomyopathy-related sudden deaths in individuals between ages 10 and 45 over a 12-year period between 2005 and 2016. Circulation published this study. The study cohort included two different populations, those without a prior diagnosis of hypertrophic cardiomyopathy, which was 70%, and those with a known diagnosis of HCM. This group, led by Dr. Paul Dorian from Ontario, used data from the Chief Coroner's Office. And the authors confirmed HCM with autopsy, and in those sudden deaths without autopsy but a known HCM diagnosis, HCM was considered probable. The autopsy rate in this study was 94%. And the data, here it is. In this 12-year period, the authors found only 44 definite cases of HCM-related death, 3 probable deaths, and 6 cases of possible HCM-related sudden cardiac deaths. These absolute numbers correspond to an estimated annual incidence rates of only 0.31 per thousand HCM person years. That's for definite HCM-related sudden cardiac death. Now, when they added aborted SCDs and appropriate ICD shocks, the estimated annual incidence rose to 0.84 per thousand HCM person years. That's low, but two other important findings, and I'll come back to that low incidence. Two other important findings: 70% of sudden cardiac deaths occurred in previously undiagnosed individuals. The low number of sudden deaths in previously diagnosed individuals, only 16 sudden cardiac deaths in 12 years in the present study, represents a much lower incidence than previously reported in this group of individuals. And second big piece of data is that most sudden death occurred during rest or light activity. 65% for the former, 19% for the latter, and I'll come back to that in the end. Look, this is an important study. First, the incidence of sudden death was much smaller than would have been expected based on the previously reported incidences of HCM-related death. Before this study, the incidence of SCD from hypertrophic cardiomyopathy was usually cited as 0.5 to 1% per year. That's 5 to 10 cases per 1,000 HCM person years. Based on these SCD incidence rates, the authors would have expected to find more than 700 cases. Instead, they found only 53 cases. That's an order of magnitude lower. Now, obviously, the author's first job in their discussion is to compare the rates to more recent reports and contemporary reports of HCM. Here, the largest set of data comes from the group of Dr. Christopher Samsarian et al. In Australia, and they also found a low rate of sudden cardiac death in individuals less than 35 with HCM. This paper, which was published in the New England Journal, reported an annual incidence of HCM-related death of 0.6 per 1,000 person years. Again, a very low rate. Now, another study they cited in the paper, and on the surface it looks to have a higher incidence of HCM-related death, is an Oregon population-based study that found an incidence of 2 to 3 per 1,000 HCM-related deaths. But this study, this Oregon study, had autopsy data available for only 33% of the deaths, so the authors speculate that this may be an overestimate. Now, the lower rate of SCD, sudden death, in this paper and in the Australian study is even more dramatic and novel, given that the prevalence of HCM is likely higher than the reported 1 in 500 cases. A recent study using MRI found that HCM may occur in 1 in 114 athletes. Well, this is kind of a big finding, because if the prevalence is much higher than 1 in 500, then obviously the incidence rates of sudden death reported by the authors from Ontario may be much lower than estimated. Now, underlying all this is that HCM represents a classic low probability, high consequence problems. And the authors acknowledge this. They write, although the risk of sudden death in most individuals with HCM is extremely low, a small proportion of individuals with HCM are indeed at increased risk of sudden death. On the matter of exercise in HCM, this paper also provokes us to think about the current prohibition on high-intensity exercise. For instance, in this paper, almost 85% of all the deaths occurred at rest or with light activity. And since the proportion of sudden cardiac deaths related to exercise was similar in this study between individuals with and those without a previous diagnosis of HCM, exercise restriction seems unlikely to explain the low frequency of exercise-related sudden death that they observed. And get this, the authors estimated the incidence rate of death associated with exercise as 0.064 per 1,000 HCM person years. Translated, that's 6 in 100,000 person years. So I love it when the authors were allowed by the reviewers to write this in the discussion, quote, "The low frequency of sudden cardiac death in hypertrophic cardiomyopathy and its rarity during exercise may be relevant in the consideration of the value of pre-participation screening for HCM, which is mandatory in several countries, and in exercise restriction recommendations." So an American translation of this Canadian careful speak goes something like this. The incidence of HCM-related death on the field is so darn low that it makes no sense to screen athletes, as the chance of reducing a death rate of 6 in 100,000 to anything lower is unlikely, and the risks of false positives and harm from overdiagnosis is huge. What's more, since the vast majority of HCM-related death occurs off the sports field, if you are a screening proponent, you must advocate screening everyone, not just athletes. Final topic today is about clinician wellness. Now, Medscape Medical News has a neat story from the ACPH meeting. Now, you don't know what ACPH is. Neither did I. It's the American Conference on Physician Health. Now, the story describes 3 ways different hospitals are helping to reinforce the incredible meaning there is in our jobs. One was a program led by a palliative care team at the University of Colorado, and these were called Good Grief Rounds. And these were an hour-long program that used storytelling to debrief emotionally difficult cases in healthcare. The stories are often combined with a poem or other reading from the literature. The abstract presented at the meeting described the success of this Good Grief program at the University of Colorado. Another example, this one from Dr. Mary Wyrus from Kaiser Permanente in Seattle. She got help from Suzanne Coven's program from the Massachusetts General Hospital, and they've started in Seattle a pilot program of after-work sessions in which doctors get together to discuss selected mix of poems and essays and short stories. Finally, Dr. Colleen Farrell, a resident doctor at Bellevue, took the concept of physician wellness and humanities online and started a Twitter chat called @MedHumChat. And this attempts to bring poetry, literature, art into the healthcare conversation in a Twitter chat. Now, one aspect of the positive feedback on these 3 programs has been the value in getting to talk to other colleagues, especially those from outside your specific field. Dr. Farrell seems wise beyond her years as she commented in the news stories that medical humanities is not the solution for everything that ails healthcare, obviously. If you're up all night and asked to do more, poetry is not going to help. But these presentations make the podcast because This Week in Cardiology recognizes that medical care is delivered by humans, not robots. I chose the passive voice there on purpose. In the last few years, I've traveled a bit and witnessed healthcare delivery in other places, and I've talked to caregivers in other health systems. And the thing that I take away from these conversations is that while the settings may be different, many of the human struggles are the same. Having time enough to work and care for a family. Having enough support from administration to adequately care for our patients. And having a space to enjoy the wins and mourn the losses that happen every day in the hospital or clinic. Just yesterday, a man told me he'd quit smoking after 60 years of smoking. He quit 1 year ago on the day I saw him last year and gave him my usual smoking speech. My smoking speech almost always fails, but not this time. So later that day, I went around to colleagues and told them about my success. Not with a catheter or a device, but with words. Similarly, when we have our bad outcomes or our emotionally draining encounters, having time to talk with colleagues about these are so important. Now, the doctor's lounge, especially at our hospital, used to be the place for these stories. The advent of the electronic health record has changed the dynamic of the hospital and the doctor's lounge. You don't see colleagues as much. People can come in, see their patients, and do their notes at home or in a quiet cubby off the floor. And more people eat lunch while doing data entry in their offices. Thus, efforts to bring clinicians together will have to be more active. We'll have to try to do this, like those presented at the American Conference on Physician Health. So that's it for This Week in Cardiology. As always, I'm grateful that you listened. Thank you. And remember, please, if you like this podcast, tell a friend. Consider subscribing, giving us a review so that other people can find us. Next week, I'll have some comments about my trip to Scotland. I'm quite nervous because I'm speaking in the same session with Professors Daryl Francis and John McMurray, so I'll let you know how that goes. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.